So this is a little bit outside of the lung rats topic, but still within the lung cancer topic. And I was just going to show you some cases of lung cancers that looked benign originally, but they were all proven by path. Hopefully this will be helpful in your daily practice. So basically this is going to be cases that didn't look like cancers, but ended up being cancers. And I'm going to show you this one here. And this is a nodule that was found on an x-ray on a smoker, big time smoker. And think about it, like, are you comfortable enough calling this a granuloma? It has a very large central calcification in it. So whenever you see a granuloma or a big calcification like that, one of the first things that I want you to take home is that if he has a lot of tissue around it, you should start trying to think, well, let's just analyze this a little more. Just don't diff it off as a granuloma. And if you go back to the hilum, there's a lot of soft tissue there in that lymph node. There's a tiny calcification there, but there's a lot of soft tissue, more than in relationship to that calcification. And if you go back to your multiplanar reconstructions, you can see that that calcification is actually eccentric, not as central as it looked in the axial planes. So this ended up being a poorly differentiated adenocarcinoma with a fibrogranuloma and a lymph node met. So just again, looking at things in different planes is very important when you're addressing nodules. It really looks central, it really looks like this in your axials, but when there's so much tissue, you should look at things in different planes, not only in your ground glass nodules, but also in your solid nodules. And this, if you're not sure, I mean, you can get a follow-up. If this is a cancer, you just don't let it go. Get a 3-month follow-up and see what it looks like. This is another example of a very tiny calcification compared to the whole size of a nodule. This is more obvious in your axial, but it might not be as obvious. You don't know in which plane is going to be obvious. So whenever you have pseudocentral calcifications, just make sure that you rigorously assess it. Use your orthogonal planes, and if there's too much tissue, just take a look again. And it's not that the granulomas become cancer. It's just that a cancer grew next to them and engulfed them. So don't go home thinking that granulomas do become cancers. And you know, lung cancers can have calcifications, not just engulfing granulomas per se, but it's not that common. Just be aware that it can happen. This is a case of a possible aspergilloma. And we had this patient that had a little cavity right here with a filling defect. But if you notice, there's a crescentic area underneath that filling defect. It's not like touching it. The patient is on their back, that should be touching the back of that cavity. So that should catch your eye. And for some reason, we recommended a CT, but the patient got scanned within a month, or I don't know if it was a PE study or what. But you could already see that that's growing. If that was the first time we had the case, this does look like it's dependent there. But if you see something changing that fast, you should be aware that that's not normal. Aspergillomas don't do that. So this was a non-small cell lung cancer. And what I want you to take home from this case is that you should always try to confirm that the nodule is dependent. If there is a crescent of air underneath, that should always catch your eye. Sometimes doing prone or the cubitus CTs help. You can just bring the patient back if they're still in the hospital, or just bring them back and don't charge them, because that's going to give you a lot of information. And tumors usually don't change in position, whereas aspergillomas do. And the aspergillomas can grow over years, but usually they don't change in a month or two like this one. And if you're not sure, and something doesn't look right, trust your instincts and follow it up. It's just better than just letting it go. This is another case of a cavity that really it screams cancer. It's just thick, it's irregular, there's inflammation around it, and it has a nodule in the middle that is non-dependent again. So what would you do with this? Would you call it also an aspergilloma? Or, you can bring the patient back and have them on their side and prove that that thing is just not falling down like aspergillomas are supposed to do. However, when they were about to, this was to do the biopsy, and they felt that it really looked like an aspergilloma, and they considered a follow-up because the cavity was irregular, but when the patient back, he got lost to follow-up, and that was a big lung cancer. So one thing to remember is that sometimes lung cancers grow that fast, and so fast that they outsource their blood flow, and they can look like big cavities. And when you see a cavity that is irregular, just follow it up, don't let it go. And relatively thin walls, what I say, I mean, this is not thin, those are thick walls, but you should just be aware that a lung cancer can present also like a cavitary lesion. Now a little bit about focal, like cysts and cancers around cystic spaces. I'm gonna show you here a case of someone that got scanned and was asymptomatic, and we had a prior 3 years ago, and it was very obvious that there was some thickening around that little cystic thing there. It's not very, it doesn't project very well, but it was ground glass, it was not really solid. So if you don't have a prior, I mean, you don't know if that's inflammation or not, but a cystic space with thick walls, even if they're ground glass, should be something that you regularly follow up. You shouldn't let it go. And this was an adenocarcinoma. So we had classic teaching in the past, but the classic teaching was that cavities with wall thickness less than 4 millimeters were almost always benign, but we've learned a lot about lung cancer through all these screening trials and very thin slices that we do. And this study about the 4 millimeters was done in X-rays, not on CTs. So there are two cancers here, and I'm sure you're going to think these are the two cancers, but actually the cancer was squamous cell carcinoma here and here. This was just blastomycosis in someone. So this is just to show you that this is very thin compared to this, but it's kind of bumpy, lumpy, and irregular. So that should always catch your eye. And you can see it in another plane again, like see how there's nothing around this. This is not a cyst, this is probably emphysema. This is a cyst. But you can see it's very irregular and almost like spiculated, and that was proven squamous cell. Another thing that I thought was very interesting, this was a study done for lung cancers associated to cystic spaces based on the LCAP study. And they went back and found all the lung cancers that were associated with cystic spaces, and they found that they found a total of 26 cancers, and half of them were diagnosed at baseline, and half of them developed over that study. And I found it interesting that the cancers that were diagnosed at baseline were thick 4 millimeters, and when they were diagnosed in the follow-up studies were almost double the size. So I feel like we're not very good at picking the lung cancers as we follow them up. If you don't have a comparison, it's easier, but if you have a comparison in a year, remember that it's not going to change a lot. So try to always compare to things that are all, I cannot say that enough. And this proves that point. I mean, usually the wall thickness appears in between 12 and 118 months. That's a long time. So going back as far as you can is the only tool that you can have at this point. Also remember that the thickness, it's not always solid, it can be ground glass, and that it doesn't always happen around emphysema, it can happen around lung cysts too. And another thing that I found very interesting is that the cyst, almost the same amount of cyst shrank in size than grew. So if you see that the cyst becomes smaller, that doesn't mean that that's benign. Even if the whole thing starts collapsing, it can still be cancer, and it's almost the same amount of people that grew the cyst that the cyst shrank. This is another case where you can see there's a little bit of thickening here, and if you're going very fast, you may just go through that as nothing, focal atelectasis, whatever. But as your follow-up, you see there's like a little bump there. If you look at it in a different plane, though, it's very obvious there is a mural nodule there. So again, looking at your planes things in different planes always helps you and should be routinely done. This is another kind of scary case where we saw this very linear opacity, and I'll just blow it up to you so you can see that if you look at it in this plane in axial, it just looks like a half moon, kind of linear. But if you look at it in the coronal and the sagittal planes, there's volume to it. It's not flat. So even if it looks linear and ground glassy, if things are not flat in orthogonal planes, just follow it up. And as you can see here, it became a little thicker, denser, spiculated, and that was an adenocarcinoma. I mean, these tend to be usually benign behavior cancers, and probably if you miss it the first time, second time it's not gonna be metastatic, but still it's worth remembering that things should be always checked in different planes. This is another non-small cell lung cancer, and you can see that it's sort of linear, but it's irregular. It has a cystic cavity to it. So those are things that we have to keep in mind every time we read CTs. Check them in different planes, and shaggy irregular margins or cystic areas are concerning. Now, this is a cancer mimicking hamartoma. And this was a new nodule in a woman that was found on an X-ray. So the new word here is important because this one was not present on an X-ray a year before. And if you see it it's very round, well-defined, doesn't really have spiculations. And if you see it, it's kind of low density in the center, but it's not as low density as the fat. If you can always go, you can always go check the fat in the soft tissues, in the subcutaneous tissues. So we've all learned that you just measure the density and see if it's fat density or not. It's just a hamartoma. Well, see these two different Hounsfield units, and I want you to take home here that if you measure these densities, you kind of just point a dot there. You have to grab a circle and put it there, because this is soft tissue density, this is not. And this was a cancer. And there are studies that have shown that macroscopic fat assessment is the most reliable method, but you have to measure the inner thirds of the lesion. If you measure the edges, it's going to average with the lung density, and it's going to give you a false negative number of being really negative when it's not. And some people have proposed at minus 33 Hounsfield units to be a good cutoff, but you have to have an ROI with 8 pixels. It's just not putting a pixel right there. And necrotic lung cancers can look low density, so this is important to keep in mind. And the other thing that I mentioned at the beginning, this was new, so hamartomas have a volume doubling time on average of more than a year, so they don't grow like that. So if you see something growing at its central low density, just don't blow it off as a hamartoma. Then I think we've all have seen this type of cases of consolidations and being lung cancer. I mean, that's kind of probably the most common thing. And this was a guy that was immunosuppressed and came with pneumonia and had this right middle lobe consolidation and patchy opacities everywhere. So I mean, he was treated, he got better, he went home. So it's not, I mean, I don't think any of us will have called this cancer ever. But he came back 4 months later with worsening symptoms, and he still had that right middle lobe consolidation. It was a little bigger, but you can see, well, there was a huge diffusion, but he has like all these kind of nodular aerospace opacities that if you went back, they were all there, they were just becoming bigger and denser, but in the same spots. So infections kind of come and go, they don't stay the same place. And he was thought to have an opportunistic infection because he was immunosuppressed. So they got a BLL, they cultured him, and everything came back negative. So, I mean, we managed this patient well. And because everything was negative, he got a biopsy of the right middle lobe consolidation, and it was a mucinous adenocarcinoma. So I think mucinous adenocarcinomas are kind of fascinating in a way that they spread through the airways, and they kind of look like infection, and they're common, they can really mimic and trick you. So just keep in mind that if you see a consolidation that doesn't go away and it's kind of the same place but a little bigger, that you should think of adenocarcinoma. Not that you're going to call every infection an adenocarcinoma, but just keep it in the back of your head. And this is another cancer of the same type of tumor, but the patient was a heavy smoker and he had no symptoms at all. So that should be something that prompts you off to be concerned about a consolidation. So remember, lack of symptoms, if the patient doesn't get better, if the cultures are negative, you start thinking about adenocarcinomas. They kind of tend to do that. If you're ever going to biopsy these, just avoid the areas of necrosis because these are going to come back negative. And this is something that is kind of controversial depending on who you ask, but people feel good when you follow a consolidation in a smoker or someone that is 50 years old. I like doing it particularly because we've seen so many cases like that. Important thing is that you have to give it some time for things to resolve. An infection can look worse in a couple weeks after treatment. And the other thing to remember is that this is not a guideline. This is up to you. And you don't have to get a CT. You can just do an X-ray. And this is a case, this is a scary case, but I think you can learn a lot from this. It was a man that came with dyspnea, and he was found to have multiple PEs bilaterally, as you can see here. But when we were running through the MIPS, we do MIPS in oropharyngeal CTs routinely. You saw that this area of tree and bud nodules, and these were only in that area. They were segmental and not dependent like when you see when someone aspirates. So since I already told you, when you see tree and bud nodules, you should always go back to look at your airways. And you can see that right middle of bronchus is just completely gone there. If you're just not looking for it, you might just pass through it very easily. And in the soft tissue windows, just looks like this PE. The thing is that this is next to the artery. That's not a PE, that was the whole bronchus filled with tumor. So there was an obstructing lesion there, and this was someone with squamous cell carcinoma. So it's hard to run the airways, especially if you're reading a PE study. And I find it very helpful to run the airways the same way that I run the PEs. So if you go like, I just count the segments. I go right upper lobe, 1, 2, 3, apical, anterior, posterior, and just try to do it the same way that you run your vessels. And that way, if you're always consistent, you're less likely to miss a lung cancer. So remember to always look centrally if you see your tree and bud nodules. And I want to show you this study that was done, very interesting in people that knew, these were missed lung cancers, and the radiologists that were doing this study knew that the people had lung cancer. And they missed a lot of them, even knowing that the patients had lung cancer. And 67% of the lung cancers that were missed were endobronchial. So again, this is our blind spot in CTs. And most of the nodules that were missed, or the cancers that were missed, even if they were solitary pulmonary nodules, were central rather than peripheral. So when you run the airways, you're actually, the cancers that are round and medial are gonna pop up on you. So you're not only gonna not miss your endobronchial lesions, you're gonna not miss your central solitary pulmonary nodules. And this is actually different than X-rays. In X-rays, we tend to miss the cancers in the upper lobes because of the clavicles and the peripheral cancers. In CTs, we miss the cancers in the lower lobes and centrally. And these lesions were not small. It's just to tell you that if you're in a rush, you just can't go through them. So running the airways is very helpful. So again, I'm gonna make a summary, take home points. If you see too much tissue in a granuloma, just go back and look at it in a different plane, as well as look at things in different planes if they're linear. Aspergillomas should be mobile, and they may grow, but they grow slowly. They don't grow over a month or two. If you have a wall of a cyst that starts becoming inflamed or thickened, just follow it up. Go back as far as you can to compare it, and the cystic spaces can shrink. That doesn't mean that it's benign. And when you see your tree and bud nodules, I've mentioned this several times now, go back and look at your airways. And I find it very helpful to run in them the same ways as I run the PE studies. So thank you for your time.